Hello, and welcome to A Sound Constitution here on CHLY 101.7 FM, a show where we focus on health topics that are important to our community. This year's team is made up of 7 third-year VIU nursing students. Our goal is to demystify health issues and address common misconceptions by sharing evidence-informed information from a variety of reliable sources. All information provided in our show will be available in our show notes on our Facebook, YouTube, Instagram, and Spotify pages. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have any questions or concerns about what's being discussed, feel free to reach out to us on Facebook, YouTube, Instagram, or Spotify at asoundconstitution, CHLY 101.7 FM, or email us at asoundconstitution@gmail.com.
We would like to start our show by acknowledging that we are on the unceded territory of the Snuneymuxw people, with a broadcasting range that overlays the Kewatsin and the Sliamon territories. This acknowledgement is done with the gratitude to the Snuneymuxw people and with the intention to increase awareness about truth and reconciliation processes and the efforts that have been made on Vancouver Island. Additional information and resources surrounding reconciliation, protocol, and land acknowledgements can be found in our show notes.
Today, we will be talking about some of the health resources that are available to use if you need or believe you need medical advice or attention. We will also be discussing what happens when you go to the emergency room and getting a behind-the-scenes look at some of the action that occurs while you or your loved one is there. We will be joined by Armand, a registered nurse who specializes in emergency nursing and critical care transports. As well, we will be joined by Dr. Alex Goldfarb, an emergency medicine physician, to discuss your care. Myself, Kira, and Broyden will be guiding you through today's episode. We'll start off our episode by talking about who you can call if you have a health concern. First, we'll explore 811. Off to you, Kira.
Have you ever had a health question late at night and weren't sure what to do? Maybe your child has a fever. Maybe you've started a new medication and you're noticing side effects. Maybe you're wondering if something can wait or if you need to seek care right away. If you live in BC, there's a free and confidential service that can help, and it's as simple as dialing 811. 811 is a provincial health information and advice line offered through HealthLink BC, which is part of the Ministry of Health. It was created to give people direct access to trusted, evidence-informed health information and to help them navigate the healthcare system more easily. The service is available to everyone in British Columbia, regardless of age, background, or whether you have a family doctor. You can call for yourself, your child, a parent, or someone in your care. It's designed to be accessible and inclusive for all residents of BC. So what happens when you call? When you dial 811, you'll usually first speak with a health service navigator. Navigation services are available 24 hours a day, 7 days a week. Navigators can answer general health questions, help you find services in your community, connect you to the right health professional, email you reliable health resources, and help you register for a family doctor or nurse practitioner through the Health Connect registry. If your question is simple, like what temperature counts as a fever, or when does my child need their next vaccine? A navigator may be able to help right away. If your concern requires more clinical support, they'll transfer you to the appropriate health professional. Registered nurses are available 24/7 to assess symptoms and provide advice for non-emergency concerns. They can help you decide whether home treatment is appropriate or if you should seek in-person care. Nurses also provide education on chronic illness management, mental health, palliative care, and overall health promotion. Registered dietitians are available Monday to Friday, 9 a.m. to 5 p.m. They provide nutrition education and counseling for conditions like diabetes, heart disease, kidney disease, gastrointestinal concerns, food allergies, and cancer. There are also dietitians specialized in oncology and pediatric nutrition to support individuals undergoing cancer treatment or families with infants and children. Qualified exercise professionals are also available Monday to Friday. They can provide personalized guidance on physical activity, sedentary behavior, sleep, and healthy lifestyle habits. They help with goal setting, overcoming barriers, and creating safe movement plans. even for people with chronic conditions or physical limitations. Pharmacists are available from 5 p.m. to 9 a.m. 7 days a week, which is especially helpful when your local pharmacy is closed. They can answer questions about prescriptions, over-the-counter medications, side effects, missed doses, natural health products, and vaccine safety. With your permission, they may review your medication information to better assess your needs. In some cases, after speaking with a nurse, you may be referred to a physician through HealthLink BC for additional medical advice. However, it is important to know that physicians at 811 do not provide sick notes or routine prescription refills. Another common question is, what if English isn't my first language? Translation services are available in over 130 languages. When you call, you can request an interpreter in your preferred language. This ensures that language is not a barrier to receiving safe and accurate health information. Overall, 811 offers trusted health advice, symptom assessment and guidance on next steps, medication support, nutrition counseling, physical activity guidance, and help navigating health services in your community. It is important to remember that 811 is for non-emergency concerns. If you are experiencing a life-threatening emergency, such as chest pain, difficulty breathing, or signs of stroke, you should call 911. But for everything else, when you're unsure, worried, or just need reliable information, 811 is there to help. It's free, it's confidential, it's available 24/7, and it's designed to empower you with accurate information and connect you to the right care at the right time. Stay tuned, as later we'll continue our conversation about community health resources and explore how services like 811 support health literacy and informed decision-making across British Columbia.
Wow, thank you, Kira, for all that great information. I've always heard 811 referred to as the nursing line, and I had no clue that it has so much more to offer.
Now that we've learned about 811, let's shift gears and talk about 911. While 811 is for non-emergency health questions, 911 is for situations where someone's life or safety is at an immediate risk. In British Columbia, 911 provides direct access to ambulance, police, and fire services. For this segment, we're focusing specifically on when to call 911 to reach emergency health services. So when should you call? 911 is meant for emergencies only, situations that require an immediate response. You should call 911 if someone is experiencing chest pain or tightness, choking or trouble breathing, loss of consciousness, signs of a stroke such as sudden weakness, confusion, or difficulty speaking, severe burns, a seizure that is not stopping, drowning, a severe allergic reaction, a serious head injury, or major or uncontrolled bleeding. If you're ever unsure whether something is a medical emergency, it is always safest to call 911. However, not every health concern requires an ambulance. If the situation is not life-threatening, you have other options. You can call 811 for confidential health advice 24 hours a day. You can visit an urgent care center or a walk-in clinic if it's safe to do so. You can call your pharmacist with medication questions. If poisoning is suspected, you can contact the BC Poison Control Center. And for mental health concerns where there's no immediate danger, crisis lines are available. But if someone is in immediate danger of harming themselves or others, call 911 right away. Now, what can you expect when you call 911? First, try to stay calm, speak clearly, and listen carefully. Emergency medical call takers are highly trained professionals. They ask specific questions in a specific order to gather the most important information as quickly as possible so paramedics can respond effectively. You will be asked the exact location of the emergency, an apartment number or access code if needed, a phone number in case the call gets disconnected, and a clear description of what is happening. While the ambulance is on the way, the call taker may continue asking questions such as, is the patient conscious? Is the patient breathing? Are they having chest pain? Is there severe bleeding? It's very important to stay on the line unless the call taker tells you it's okay to hang up. They may provide instructions to help you care for the person before paramedics arrive. There are also simple things you can do to help. Ensure there is a clear path to the patient, unlock doors, have someone wait outside to guide paramedics in, make sure your house number is clearly visible, turn on outside lights at night. In an apartment building, meet paramedics in the lobby and have the elevator ready. Avoid moving the patient unless their life is in immediate danger. and secure pets in another room for their safety as well as the paramedics. Calling 911 activates a coordinated emergency response designed to provide rapid, life-saving care. Knowing when to call and what to expect can make a critical difference in an emergency situation.
Now that you know who to call, where can you actually go? Let's take a look at some of the health facilities that are available.
There are times in a person's life where they decide that they need to seek medical assistance, and sometimes it can be hard to determine when and where to go. Depending on where you live, you may have access to walk-in clinics, urgent care services, or emergency rooms. So let's break down our choices to better understand our options. So let's start with walk-in clinics. Walk-in services are best used in cases which medical care is needed, but not life-threatening or urgent. Some examples of these cases include minor injuries, such as cuts or sprains, or even prescription refills. Walk-in clinics typically operate similarly to how a family doctor or nurse practitioner office operates in terms of what services they may provide. That being said, something to keep in mind is that walk-in clinics, despite the name, often require you to book an appointment ahead of time. Be sure to visit HealthLink BC for assistance in finding walk-in clinics near you and what they can provide for you. Moving on to our next location, urgent care is considered as the in-between of walk-ins and emergency rooms, and it is best utilized for medical issues that will need to be addressed within 12 to 24 hours. Some examples of urgent care that can help with are illnesses such as severe colds, low-grade fevers, sore throats or ears, as well as minor rashes. Injuries such as cuts, burns, sprains, back pains, or minor eye injuries, and even sexual health services such as STI screening, pregnancy testing, and support for sexual assault. Urgent care may also be able to provide medical imaging such as x-rays in cases of where you may think a bone is broken. Be sure to check with the unit you plan to visit to see if they are able to provide the services you need. Last but not least, the emergency room is best used when you or someone you know is experiencing a life-threatening emergency, or that you feel you need to be seen by a doctor sooner than the other options would allow for. Services that the emergency room can provide include, but not limited to, trouble breathing, severe abdominal or chest pain, weakness or tingling on one side of the body, loss of consciousness, and heavy bleeding. As we'll also learn later in this episode, the emergency department does not work on a first-come, first-served manner. Patients will need to be seen and treated based on a number of factors depending on how ill or injured they are. If you are unsure if what you or someone you know is experiencing is enough of an emergency to warrant a visit to the ER, HealthLink BC recommends that you call 811 for further advice about whether the ER or urgent care is the best option for you. We mentioned earlier that 811 provides interpretation services for non-English speakers. For people who are deaf or hard of hearing, can call 711 to accommodate their needs. Please visit HealthLink BC for more information. When visiting any of these services, be sure to have your BC Services card or your personal health number available and be ready to describe your symptoms to the healthcare staff, as they will need to be able to assess the severity of your issue and where you can receive the best care. Your personal health number can be found on the back of your BC Services card or your driver's license. If you don't have a family doctor or a nurse practitioner for health advice, you are able to register to be matched with one when spots are available. You can register at healthlinkbc.ca/healthconnectregistry, and you will also need your PHN, home address, email, and phone number when registering. As we discussed earlier, 811 can also assist with registering for non-English speakers. After registering, the team in the community that you will be matched with, when spots are available, will contact you either through phone or email to offer further information. Also be sure to have your Health Connect registry updated while you wait to be matched with a family physician or nurse practitioner to prevent any delays in the matching process. If you are curious about wait times to be matched with a doctor or a nurse practitioner, Health Data BC provides a website dedicated to providing average wait times for each community. This is provided as a means to allow our community to have visual data on wait times to receive primary health care. However, it is important to note that this service only has a limited amount of reliable data on exact numbers or geographical distribution for healthcare services. So when using this source, please remember that the numbers you see are approximate, not exact, to emphasize the average wait times based on the information we currently have. As you can see, BC provides many services when it comes to medical or health issues. When deciding on visiting one of these services, remember to look up if the facility needs an appointment or if they have the equipment necessary for your emergency. If you are still unsure, visit HealthLink BC or Island Health for further information on which service is best for you.
If you're just tuning in, welcome and thank you for joining us on CHLY 101.7 FM. This is Asound Constitution. Today's episode has so far explored available health services. We've discussed when to phone 811 as well as 911. Additionally, we have talked about when to go to a walk-in clinic, urgent care, or the emergency room. Next up, let's take a closer look at what actually happens when you go to the emergency room. How do they know who needs to be seen, and when? When you arrive at the emergency department, either by ambulance or on your own, the first emergency room staff you will usually see will be the triage nurse. It is their responsibility to assess every patient, then assign an acuity score. We'll learn more about that process later on in this episode. For now, let's take a look at what that scoring system is. What is now called CTAS, the Canadian Triage and Acuity Scale, began after Dr. Robert Beveridge studied the Australian National Triage Scale in the 1990s. Initially introduced as the Canadian Association of Emergency Physicians 5-level Triage and Acuity Scale in 1995, a working group with many national organizations was formed, and CTAS was formally published in 1999. But what is it? This 5-level scoring system allows triage nurses to determine the severity of a patient's problem and communicate that severity to other health professionals. The 5 levels range from 1 to 5 in order of acuity. There's resuscitation, emergent, urgent, less urgent, and non-urgent. While the initial CTAS level is never changed, if a person's status changes, assessments will take place by nursing and physicians, and that acuity change will be documented and made known to all staff. The CTAS system allows for every patient, regardless of what emergency department they go to be assessed and graded in the same standardized, reliable way. The triage process itself ensures critically ill or injured patients receive priority attention. It establishes acuity and anticipates the resources needed for those patients, and it also predicts how long the patient can safely wait to be seen by a physician. As we will see, the triage process is very complex and requires very skilled individuals. Whether a person arrives by ambulance or walks in the emergency room doors, the triage nurse almost never knows what to expect. They are constantly assessing the waiting room, prioritizing patients. When they have patients at the desk, they assess, question, and document on every patient that they see, and using different policies and procedures specific to where they work, the triage nurse can set in motion a lot of the appropriate interventions, and we'll see what some of those interventions are in our upcoming interview.
We now have had a brief overview of what CTAS is, how it came to be, and how it helps to prioritize patient needs. We also have a beginning understanding of the role and importance of the triage nurse. However, there are still many questions left unanswered. Our first guest today is Armand, a registered nurse who specializes in emergency nursing and critical care transports. He joins us today to help demystify the emergency department and provide insight into the patient experience.
Joined with me now, I have Armand. He is a registered nurse trained in emergency nursing as well as critical care transport nursing. We are going to be discussing today what happens when you or a loved one needs to come to the emergency department and get a good overview of some of the behind-the-scenes stuff that patients might not be aware of when they come to the department.
Okay, so yes, as you mentioned, my background is as an emergency RN. I've been an RN for getting on close to a decade now, but I think I'm in my 9th year. I started out in acute medical unit. Eventually, I transitioned over to emergency, did additional training specializing in working with undifferentiated patients in an emergency environment. Worked that for a few years there, and for the last couple of years, my main job has been as a critical care transport nurse, meaning that I spend most of my days in the back of an ambulance with sometimes very sick patients who need to move between facilities to, generally speaking, larger sites, bigger hospitals that have more services that are not immediately available at the center where they first presented.
Okay, that's quite interesting. So you really help patients get to where they ultimately need to be.
That's our motto, is getting patients to the care they need.
And you mentioned undifferentiated patients. Can you just explain to our listeners what that means and how that's different from a nurse that may work on a medical or a surgical floor with their patients?
Sure, that's a very, very good point. It's a very important distinction. When you picture a patient in the hospital, your first mental image is likely of somebody in a hospital bed. And most patients in the hospital, once they're admitted to the hospital, they're admitted with a diagnosis. That is, at least in provisional terms, there's a good sense of what disease process, whether it's medical or surgical, that is taking place or what steps are needed to help them get better. However, the emergency department is a rather unique environment in that people coming in are a bit of a mystery still. We don't know really what's happening aside from the fact that they feel unwell, generally speaking. And that's the job of the emergency team to get to the bottom of it to some extent, to help differentiate between what can be a life-threatening condition or presentation to something that is maybe less acute, and to ultimately figure out whether this patient is someone who requires some treatment in the moment and they are able to further recover at home, or whether they need to come into the hospital for a longer stay.
Yeah, the emergency department definitely seems quite unique in that way, that you never know what's coming in, and it's really the whole team's job to figure out what needs to be done. So in today's episode, we're focusing on what happens when patients need to access healthcare, where they should go, and what to expect once they get to those places. So with a focus on the emergency department, we had briefly introduced earlier in the episode CTAS, or the Canadian Triage Acuity Scale. I was wondering if you could tell us a little bit about the role of the triage nurse, who's the nurse that patients will see when they first come into the department, and how a patient's acuity level is determined.
Yeah, so the triage nurse is, generally speaking, one of the more senior nurses in the department. This individual will be there to perform a very brief, very rapid assessment of every patient that walks in through the door who's seeking medical attention. The idea is they will do, largely speaking, two things. One is they will determine, and what CTAS is used for, is to determine roughly how quickly they require to be seen by a physician. And so patients are assigned a score between 1 and 5, with 1 being patients who require immediate resuscitation, or resuscitative efforts are actually underway. These are patients who at the most extreme end might be those without a pulse, or otherwise so incredibly unwell that they may well end up without a pulse very quickly. And that scale goes all the way down to a 5. And those patients are individuals who do not require imminent intervention. These are generally very minor complaints, and that's not to say that that these complaints are trivialized. It's that there is no imminent threat to loss of life or limb based on these issues.
Okay, so patients with a score of 1 need to be seen immediately and their life is at risk. Patients with a score of 5 are ones who can access some of the other services that we've talked about earlier in the episode, whether it's phoning 811 to get medical advice, going to a walk-in clinic, or seeing their family physician. So there's nothing immediate that needs to be done. Is that correct?
It's important to note that we will never turn somebody away at the hospital. Patients have the right to see a physician. It's only a matter of time. It's only a matter of time. It is the CTAS score is the idea of prioritizing limited physician capacity to the patients that are presenting to the department, such that those who are at greatest risk of losing functional capacity, let's say, which can go as far as to say limb or life, will receive that attention first. And this is truly based purely on acuity. So, as I said earlier, on the one hand, the triage nurses provide this score, but this score is not a number that they make up. That is what this CTAS algorithm is utilized to do. So the idea is that based on the nature of their complaints, the nurses are guided to this score, and they do have, and part of it is also utilizing their own clinical judgment and experience in recognizing potentially more concerning findings in a patient presentation that otherwise, based purely on CTAS rules, may not seem as though they would be as acute.
Okay, and you mentioned that it's often more experienced nurses that are the triage nurses, so that makes sense that they'll have that experience where they can pick up on things that the patient might not even know is going on.
Exactly. So oftentimes the triage process is often one wherein the triage nurse is asking the patients a fairly standard battery of questions of getting to the root of their complaint. But what they will generally do is they will utilize that experience of having worked with these undifferentiated patients in emerge where we don't know what's happening to them, and they're coming in with sometimes very vague complaints that could be indicative of a number of potentially life-threatening presentations. They will sort of work systematically through various bodily systems. So, we want to see whether there's a respiratory component to the patient's presentation, whether there's anything potentially cardiac in nature, whether there's anything neurological, because that leads to one of the final parts of the triage process, wherein at some sites, not all sites, the triage nurse can initiate a protocolized series of follow-up investigations. So those include things like blood work, electrocardiograms, some x-rays, all the bits of information that the physician who will be seeing the patient in short order will need in order to come up with a appropriate diagnosis.
Okay. And that kind of leads into my next question, where I wanted to know what a patient can expect after they're triaged. So you mentioned some things that the triage nurse is, through protocols, able to implement, whether it's blood work, ECGs, x-rays, so different types of imaging. What else can the patient expect? So somewhere along the line, when these protocols are put into place, somebody actually needs to come and see the patient to do these things. What's that process look like?
Yeah, so once the patient is triaged and they're assigned to usually an area within the emergency department, the way that patients are assigned and the area that they are generally has very little bearing on how fast they will be seen. It's more likely to do with what type of equipment and assessment rooms and whatever else is in that specific area of the department. So it can be a little bewildering to be, well, why am I getting sent there when, nobody else around is looking like they've got the same kind of presentation as myself. It may be as simple as there's a piece of equipment that's in that part of the emergency department that you may require. While the patients are waiting, things have already started cooking in the background. So they may have, as I said, these numbers of investigations already initiated by the triage nurse, which may also include certain treatments like you might receive, some Tylenol or Advil if you're presenting just with some pain. Right at triage, you might receive aspirin if you ever present with chest pain, because we always have to presume everything is the worst possible thing, which with chest pain we would assume, generally speaking, a heart attack. So aspirin has been shown to be highly, highly beneficial in improving outcomes in patients presenting with heart attacks. So it is part of our order set at triage to also administer 160 milligrams of ASA. While the patients are waiting, as I said, things are starting to cook. So, for example, if blood work is ordered, which is for many patient presentations that are generally speaking, not your straightforward fall over, go boom, tripped and rolled an ankle. That generally doesn't beget blood work. But if you present in with something more nebulous like abdominal pain or chest pain or something, we'll probably want to do some blood work. So you will be seen by an MLA, a medical lab assistant. They will perform a blood draw, and that gets sent to the lab. That takes some time for the various laboratory procedures and machines to do the analyses and to report those back in the patient's chart. You may be taken by a porter to an X-ray department where we might image, whatever relevant part of the body is involved. Depending on your presentation, you might be seen by any other number of allied health providers. In the more acute side of the emergency department, we work very closely with the respiratory therapists, and they are incredibly talented folks who specifically work on the respiratory side of things. So they might come in and they may be able to initiate certain therapies or do their own assessments before a physician sees you. But the idea is that all of these investigations that we do then start to paint a picture in the background while you are, it feels like, just idly sitting still. But these are all pieces of information that we are collecting one way or another in order for the physician to be able to do the part that you came to the hospital for.
Okay, so what I'm hearing is, since patients, when they come into the emergency department, we don't know what's going on with them, the triage nurse's job is to, quickly as possible in their short assessments, is to figure out generally what the patient has come in with, what different investigations, lab work, ECGs, imaging, what that patient might need, and what the physician will need to understand what's going on with that patient. And for each person who comes in, it'll look quite different. As you said, you can be sitting next to somebody in the waiting room, and they have two completely different working theories about what could be going on with them. And then all of the information that's collected, and it sounds like it can take some time, it will start to paint a picture for when the physician comes to see the patient. But in the meantime, there's already a lot of investigations and a lot of people involved in the care of each patient that come in.
Absolutely. And so ultimately, to sort of really quickly try to sum up what the triage nurse does, and I think you've done a great job with that. It's exactly that, is to begin to initiate, figure out what direction we need to go in helping the patients that present before us. So whether it is the decisions that the triage nurse makes at the start relate largely to figuring out the general shape of the care that they will need, whether it is going to be whether we need to immediately jump in because this patient is at risk of losing their life, or again having some permanent kind of injury secondary to this presentation, to making a follow-up decision of what investigations are appropriate. And this is very protocolized, but essentially if the patient presents with something that might be something cardiac, we'll start a cardiac workup on them. If the patient presents with general sort of belly sounding stuff, we're going to start some sort of abdominal workup on them, things like that.
Okay, I think that'll give our listeners quite a good picture of what to expect when they first arrive to the department and the time after they get seen by the triage nurse. I want to get into a little bit more about your job doing the critical care transports. What does that look like? How do you find out who you need to transport, where they are, where they need to go to? What's kind of the process of the transport that the patients wouldn't be aware of?
Oh boy, yeah, that's not a small process at all. So obviously living in a large province as we do, the geography is quite staggering when you really think about it, and working across multiple sites, sometimes, as I've alluded to before, certain resources are concentrated in larger metropolitan areas, and we have in between those large metropolitan areas a number of smaller sites. Well, ultimately, if a patient who presents to a care site where they require diagnostics or interventions that are beyond the capabilities of the site where they presently are, they will require transport to, generally speaking, a higher level of care. In my specific realm, generally, what we're trained to work with is the subset of population of patients who are, generally speaking, quite unwell. The background process for that is that a conversation must take place between a sending physician, so the physician that is presently looking after that patient, and a patient at the receiving facility. This is all done through a provincial network that tracks and schedules and prioritizes all of these. Then the appropriate resources, which will involve an ambulance, like a ground ambulance, or sometimes potentially a helicopter or a fixed wing, and the appropriate care providers, which will inevitably involve some of our amazing paramedic colleagues, and sometimes someone such as myself or my immediate colleagues, other transport nurses, who will then be dispatched by this same entity to go see, assess, take whatever steps are required to further stabilize patients at whatever site they might be, and then, in my case, hop in the back of an ambulance with them and our paramedic colleagues and get them safely to the destination, to whatever site that they need to get to.
So it sounds like the patient transport network works with many different disciplines, ultimately leading to patients going from one site to another with the appropriate care along the way, so that they have a continued access to the level of care that they require.
Absolutely, yeah. There's a lot of moving parts to this system, but ultimately the idea is that the most appropriate providers, most appropriate personnel are dispatched to help provide that continuing level of care, as you said, So in my case, oftentimes that involves being able to provide ICU level interventions, whether they are medications or assessments or sometimes more specialized equipment that is required to come along with the patient in order for them to safely get to where they need to.
That's quite an interesting and complex process, and not one that I myself, or I'm sure many other people, would even think about. It's kind of seems like part of our healthcare system that we may take for granted that we can get the care that we need, but it sounds like there's a large team, just like every part of healthcare, that's involved in helping the patients get what they need.
That's a really great parallel. It's the same just as when a patient presents to the emergency department and you have a good amount of stuff that happens behind the scenes while they're waiting for their opportunity to have that FaceTime contact with a physician. It's the same in moving in between care facilities. There's a lot of moving parts that include the appropriate interventions and care has been given to the patient at the sending site, and ensuring that there is a space and services available at the receiving site. And it's a very, very complex balancing act and juggling act, really. But the end result is that our patients get what they need in as timely and safe a manner as humanly possible.
Wrapping up here, is there anything in particular that you wish patients knew when they came to the hospital, or something that you think most people don't know but they should?
First, I just want to say that I really encourage all patients to not brush off their own health concerns or the concern of their loved ones. I think utilizing resources such as 811 that you talked about earlier in this episode is a fantastic first step. And if anyone is ever on the fence, by all means, they should definitely start with that. I guess an important thing for patients to keep in mind is that, again, patients are not seen in a first come, first served manner. They will see a physician and receive the appropriate level of care in order of acuity. That means that I've encountered such myths such as if I come in by ambulance, I might be seen faster, and that's not true.
It sounds like a lot of what you're saying there is that you really want patients to be able to be comfortable advocating for their own health needs. If they think that they need to seek care, then use the available resources. And if they come to the emergency department, they will be seen, although it will be based off of their acuity score that we've talked about, as well as encouraging patients not to try to minimize their symptoms, that if you feel unwell, then we're here to help you. I'd really like to thank you for your time and for all of the really great and helpful information that you were able to provide. I really think that it's important that people seeking medical attention have a better understanding of what's actually happening, and they can feel more confident in the care that they're receiving. So I really thank you for your time.
Oh, my pleasure. Thank you for having me. It was great to have the opportunity to talk about some of these things, and I hope your listeners find it informative and hopefully even helpful.
I'm sure they will.
If you are just tuning in, this is A Sound Constitution on CHLY 101.7 FM. We have just heard from Armand, an emergency and critical care transport nurse, about what patients can expect when they come to the ER. As well, we have learned about some behind-the-scenes action that is taking place to care for patients. Next, we'll be hearing from Dr. Alex Goldfarb, an emergency medicine physician, to learn a little more about what goes into caring for patients in the emergency department.
Today with me here, I have Alex Goldfarb. He is an emergency medicine physician working at NRGH. He's here today to talk a little bit about the physician experience and how doctors care for patients in the emergency department. Thank you for being here.
Oh, thanks for having me, Trevor. I appreciate it. I am certainly by no means all-knowing, and obviously this is just my opinion, just one of many. But yeah, I'm happy to be here and kind of share my experience and hopefully help whoever's listening kind of learn a little bit more about what I do and their experience in the emergency department.
That sounds excellent. Can you tell me a little bit about yourself and what drew you into emergency medicine?
Absolutely. So, I'm actually originally from Ottawa. I moved out here when I finished my training about 5 years ago or so. And kind of growing up, I always knew I wanted to be a doctor. And funny enough, initially thought I actually wanted to do emergency medicine, and then kind of changed my mind a few times when I was training, but ultimately decided on doing this. And I'm very happy I did it. Emergency medicine really fits my personality. I find I get to move from thing to thing very quickly, and it keeps my mind occupied and constantly moving and thinking of new things. It's always very exciting as well.
It really sounds like every day can be a little bit different, and I think that's probably what some of that excitement is, that you never know what's next to come through the door and what you might need to do on any given day.
Definitely, it's excitement, but also anxiety. You know, the kind of the fear of the unknown. I think it's what makes every day interesting and a new learning experience. It certainly keeps you on your toes, and you have to know a lot about a lot of different topics. But I think that's one of the things that makes emergency medicine so interesting is the constant lifelong learning, uh, and also being able to rely on such a great team like everybody we have in the emergency department, like people like Armand, who you heard from previously.
Yeah, and Armand really touched on that teamwork, and it sounds like a lot of medicine and nursing, but especially in the emergency department, relies on such a great team because you don't know what's always coming in. So you need a lot of people there initially until you can figure out what a patient had to come in for.
Definitely. And, you know, I'm just one person in the emergency department, and the emergency department would not run without everybody you see and all the people behind the scenes who kind of keep it running from the back end.
And that's really important for people to keep in mind, I think. One of the aims of this show is to demystify health topics. Today, we're focusing on how the emergency department works. And as you mentioned, I've spoken with your colleague Armand to learn about how patients are triaged and what they can expect when they come to the emergency room. One of the things he highlighted, and you have as well, is the behind the scenes work that goes on when patients are being cared for. Can you take us through what some of that behind the scenes work looks like from the physician's lens? What things have you typically investigated, or what have you looked into before you see a patient? And what kind of guides that process?
Certainly. So I think the number one thing that guides the process, and like you've talked about previously in the show, is the CTAS score. So somebody with a CTAS 1 or who is in need of immediate care, you don't have the opportunity to go through their past medical history often. You often have to dive in and kind of immediately assess the patient. And then as you're doing your assessment or resuscitation, you can kind of pull out the past medical history or other information from the patient that you might need.
Okay.
However, for most patients, you generally have at least a few minutes to review their chart. Often you can review previous visits to the emergency department. You can see previous investigations, including imaging and laboratory investigations like blood work that's been done and the results. You can also see notes from previous physicians. So I can learn a bit more about their experience through the medical system and some of the past medical history, kind of in the hopes that I can have a better general idea of the patient and a better understanding of them, but also to try to prevent a little bit of the repetition that I think patients always experience as they go through the system.
I think that's quite important, where a lot of patients, I know when I've taken care of patients in the hospital, they'll sometimes say, "Oh, you're the third person to ask me about this." And well, the repetition is quite important to make sure that we don't miss anything, and sometimes we ask questions to make sure that what we've been told about the patient is still current. But definitely, if there's opportunities to lower the patient workload in that respect, I think that a lot of patients appreciate that. It really sounds like you can get a good idea about what has brought somebody into the emergency department. Can you tell me a little bit about some of the planning that goes on in your head? So a patient gets their CTAS score, they've been triaged, a note has been made, maybe the triage nurse has ordered some investigations. What other planning goes on in your head? Or is it a lot that you're waiting for lab results and imaging to come back before you can start that planning process at times?
Yeah, so certainly. So I think, like you touched on, some of the times the nurses have had the opportunity to order laboratory investigations, and they have certain protocols where if a patient presents it within a certain category, they can order good, kind of often great first tests that can be really helpful to guide treatment. Sometimes, if it gets really busy, the nurses are doing 10 different jobs and unfortunately just don't have the opportunity to order blood work. So sometimes that can prevent them from being ordered initially, or oftentimes I'll see a patient and I'll actually want some other tests, specific tests, or sometimes their initial complaint after you kind of talk to them more about what actually brings them in, you realize that there'd be a different cause and you need to order other tests. And I think sometimes when you see a patient, certainly when you use the blood work or the imaging, you can absolutely guide your decision depending on the results. However, you can glean a lot of information just from the history and the physical exam. And something I was taught in medical school that I didn't really kind of appreciate until you started practicing is that often your diagnosis and the disposition, or whether somebody is going to get to go home or have to be admitted to the hospital, can often be made from just talking to the patient and getting a history, because that's where 90% of your information is actually going to come from. And that's often where you'll be able to make your diagnosis, often pretty accurately, and have a better understanding of how it's impacting the patient's life and whether they can manage this condition with some assistance at home. The patient is so sick that they actually require admission to hospital so they can get cares under doctors and nurses, or if they can go home but they need short-term follow-up, whether that's with a community nurse or an outpatient physician, or potentially a telehealth visit as well.
Yeah, that makes a lot of sense. There's such a diverse group of people that come to the emergency department, and certainly not all of them need admission. So it's really good that you're always thinking about how and if a patient can be helped at home so that they don't need to come into the hospital. And then I also really love your emphasis on talking to the patient, because ultimately our computers and our electronic health record are an excellent source of information and can give a lot of helpful hints, but certainly talking to the patient in front of us is what it's all about and how we can most effectively help people.
Definitely. And I think actually that's why a lot of people get into healthcare is, the classic answer is to help people. And part of that is just sitting and talking with people and connecting with them and really understanding their lived experience. And I'm really fortunate in the emergency department that I get to interact with everyone kind of from all different walks of life, whether you're old or you're young, whether you're healthy or you're chronically unwell. Everybody at one point often has to come through the emergency department. And I'm very fortunate and privileged that I get to kind of experience everybody and get to kind of learn their lived experience. And so talking to them is certainly important with that.
Yeah, that's, well, certainly not unique only to emergency medicine or the hospital, but is a really interesting point that you bring up, that all walks of life, all ages are the patients that you take care of. And I think that really goes to show, like you were talking before, about the importance of the lifelong learning, because healthcare is always changing, and when you're taking care of every single type of patient that there is, I imagine that it's quite a workload to keep on top of. Is there anything else that you wish that people knew before they came to the emergency department, or something that you wish people knew when they were in the department?
Trev, that's an interesting question. I would have to say that I can appreciate that people often come to the emergency department when they have nowhere else to go. And I'm going to be honest, nobody comes to the emergency department because they're happy. They're often having a hard day, sometimes some of the worst day of their life. And I hope they know that we appreciate that. And we are absolutely trying our best to provide the best care possible within the limitations of our current system. Everybody everywhere is experiencing the strain of it. And I'm not here to point fingers or blame, but I just want people to know that we are trying our best. But if you are sick, please know that you still get excellent care. No matter what you hear or whatever you read, know that you can come to the emergency department if you are in need of help, and we will give it to you. And that no matter how hard it gets, you're always welcome to come if you are thinking you have an emergency.
I think that's a really important note, and a really important thing to have patients hear, is that if you're having an emergency, if your loved one is having an emergency, come in and you'll still get care. And that there's a really good team of physicians, of nurses, of lab assistants, and everywhere in between, that we're all here to help you and do the very best that we can on every given day. On that note, I'd like to really thank you for joining me today. I think that all of our listeners will have gained a lot of insight out of this conversation, and throughout this whole episode, I think that they'll get a really good insight at how our healthcare system works and some of the behind the scenes or insider information that we don't get exposed to on a daily basis. So thank you very much.
Oh, my pleasure. Thanks very much for having me.
We've just heard from Dr. Goldfarb, an emergency medicine physician, and learned what goes into treating patients in the emergency department. Between the conversations with him and Armand, I really feel like I have a better idea about how the emergency room operates and what to expect while there. I hope you do too.
This week, we've discussed some of the different health services that are available and when and how to utilize them. We've also gained an in-depth understanding of what going to the emergency department looks like and what to expect as a patient. Stay tuned to learn what we'll be discussing next week.
Women's health is trending, but not always in a helpful way. Hormone balancing, cortisol spikes, cycle syncing, it's online everywhere, and honestly, it's hard to tell what's real and what's really good marketing. Next week, we're slowing it down. We're talking about what hormones actually are and what they do. We'll unpack why women's health information spreads so fast and why certain buzzwords stick. Jess joins us to break down birth control, what it is, how the different types work, and what typically doesn't get explained well enough. Ethan walks us through perinatal health, including information before, during, and after pregnancy. Then Alexis will talk about advocacy, what to do when you feel dismissed, minimized, or not taken seriously in healthcare. We'll also be sitting down with a nurse practitioner who works closely with women in her community. She'll share what women are really coming into the clinic worried about, the symptoms that are often brushed off as normal, and how a holistic approach can change care. If you've ever been left confused after seeing women's health information online, or if you've ever wondered how you can better advocate for yourself when seeking health support, this episode's for you.
Check out our show notes from today's episode on our Facebook, Instagram, YouTube, or Spotify at asoundconstitution, CHLY 101.7 FM for details, references, and information about today's show, and our commitment to truth and reconciliation. or if you want to follow along on what's coming up this season. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you've missed parts of this episode or would like to listen to this or past episodes, check out our YouTube or our Spotify at A Sound Constitution.